Hello everyone. Today I am going to discuss the topic of calcium channel blocker toxicity and how to manage it. We will go through the detailed points step by step. First, the introductions. Calcium channel blockers, CCBs, also known as calcium channel antagonists, were widely used to treat various conditions. Cardiovascular indications include hypertension, coronary spasm, angina pectoris, supraventricular dysrhythmias, hypertrophic cardiomyopathy, and pulmonary hypertension. In addition, CCBs can also be used to treat certain off-label indications, such as Raynaud phenomenon, subarachnoid hemorrhage, and migraine headaches. There are two main groups. Dihydropyridines are amlodipine, nicardipine, nifedipine, felodipine, clevedipine. It preferentially blocks channels in vascular smooth muscle, causing significant vasodilation and reflex tachycardia. Also antagonizes calcium-mediated insulin release in the pancreas. It used to treat hypertension, coronary artery disease, and chronic stable angina. Non-dihydropyridines are verapamil, diltiazem. Selectively block myocardial Ca channels, resulting in decreased cardiac contractility, slowed AV, SA node activity, and peripheral vasodilation. Can also antagonize Ca-mediated insulin release in the pancreas, leading to relative hyperglycemia. It used to treat hypertension, paroxysmal supraventricular tachycardia, PSVT, conversion, PSVT prophylaxis, atrial fibrillation, flutter, chronic stable angina, and vasospastic angina. Mechanism of action. CCBs block the inward movement of calcium by binding to the L-type, long-acting, voltage-gated calcium channels in the heart, vascular smooth muscle, and pancreas. Two major categories of CCBs are based on their primary physiological effects. The non-dihydropyridines exert inhibitory effects on the SA and AV nodes, thereby slowing cardiac conduction and contractility. This property allows for the treatment of hypertension, reduces oxygen demand, and helps to control the rate of tachydysrhythmias. The dihydropyridines exert minimal direct effects on the myocardium and are primarily peripheral vasodilators at therapeutic doses. This property renders them useful for conditions such as hypertension, post-intracranial hemorrhage-associated vasospasm, and migraines. Pharmacokinetics. Absorption. CCBs are readily absorbed orally. However, many exhibit low bioavailability because of hepatic first-pass metabolism, primarily mediated by CYP3A4. Distribution. CCBs are highly protein-bound, and many have high volumes of distribution. Metabolism. CCBs are extensively hepatically metabolized. In repeated doses or overdose, the hepatic enzymes responsible for metabolism become saturated and reduce first-pass effects, increasing absorption of the active drug. Modified release formulations and saturation of metabolism of these drugs increase the half-life of various CCBs. The potential for drug-drug interactions is because CCBs are metabolized by CYP3A4, which is responsible for the metabolism of many other xenobiotics. Elimination. CCBs are primarily excreted renally after metabolism. Mechanism of toxicity. Verapamil and diltiazem are the most lethal calcium channel blockers in overdose. Bind the alpha-1 subunit of L-type calcium channels, preventing the intracellular influx of calcium. These channels are functionally important in cardiac myocytes, vascular smooth muscle cells, and islet beta cells. In overdose, receptor selectivity may be lost. So even dihydropyridines, e.g. amlodipine, may cause cardiotoxicity in addition to vasodilation in large overdoses. Cardiac toxicity results from excessive negative inotropy, myocardial depression, negative chronotropy, sinus bradycardia, negative dramotropy, atrioventricular node blockade. Effects on vascular smooth muscle tone result in decreased afterload, systemic hypertension, coronary vasodilation. Metabolic effects, including hyperglycemia, also occur. Hypoinsulinemia, as insulin release is dependent on calcium influx into islet beta cells through L-type calcium channels. Calcium channel blocker induced insulin resistance. Calcium channel blockers also impair the cardiac myocyte adaptive response of shifting from using free fatty acids, their favored resting state, energy substrate, to carbohydrates, due to impaired uptake of glucose and free fatty acids by cardiac myocytes. Inhibition of calcium-dependent mitochondrial activity required for glucose catabolism. Clinical features. Onset. The onset of symptoms with standard preparations of calcium channel blockers is typically within 1 to 2 hours of ingestion. Slow-release preparations. The onset of significant toxicity may be delayed 12 to 16 hours with peak effects after 24 hours. Cardiovascular manifestations. The early signs of toxicity are usually bradycardia, first-degree heart block, and hypertension. This may progress to refractory shock and death without appropriate intervention. Complications may include myocardial ischemia, stroke, and non-occlusive mesenteric ischemia. Metabolic manifestations. Hyperglycemia. Severity often correlates with the severity of calcium channel toxicity. Neurological. Seizures and coma are rare and usually signify the presence of a coingestant. However, they can occur as a late feature of toxicity due to cardiovascular collapse, as can focal deficits. Investigations. Bedside. ECG, bradycardia, accelerated AV node conduction, second and third degree heart block, sinus arrest with nodal escape, asystole. Sinus bradycardia with first degree AV block. Heart rate 45 BPM. PR interval 240 milliseconds. This type of ECG pattern is commonly seen in the early stages of beta blocker, calcium channel blocker poisoning. Complete heart block. Sinus rhythm, P. Waves occur at a rate of around 90 BPM. Third degree AV block. There is no relationship between the P waves and QRS complexes. Slow escape rhythm, 30 BPM, with a RBBB morphology. This could be either a ventricular escape rhythm or a slow junctional rhythm with RBBB. Hyperglycemia is a marker of severity. Blood gas, hyperlactemia, metabolic acidosis, impaired oxygen delivery. Laboratory evidence of organ dysfunction due to shock, e.g. increased creatinine. Imaging. Chest X-ray, pulmonary edema. Echocardiography, evidence of impaired contractility. Management. Decontamination. Activated charcoal 50 grams PO or via NGT, even if asymptomatic, unless poor airway protection. Strongly consider whole bowel irrigation for any extended release ingestion or for verapamil or diltiazem, even if asymptomatic. Initial therapy. Give IV fluids for hypertension. If symptomatically bradycardic, give atropine, 0.5 to 1 mg. Q 2 to 3 minutes, maximum 3 mg. IV calcium. If still symptomatic despite initial resuscitation, give Ca gluconate 10% 30 to 60 ml IV, 0.4 to 0.8 ml per kilogram. May also use calcium chloride 10% 10 ml, 0.1 to 0.2 ml per kilogram. IV, but only if via a central line or very secure large peripheral vein, due to risk of tissue necrosis in case of infiltration. Repeat every 5 to 10 minutes as needed. Monitor serial serum calcium. Aim for 15 mg per deciliter, or ionized calcium. Aim for double baseline level, and ECGs. Insulin. High-dose insulin can have positive inotropic effects. Start with regular insulin 1 U per kilogram. IV and infusion 0.5 to 1 U per kilogram, H titrated upward as needed. Maintain euglycemia with D10 or D50 as needed. Be mindful of hypokalemia. Vasopressors may be effective, often require high doses. Glucagon, uncertain benefit, but may increase the heart rate. Give 5 mg IVQ 10 minutes, up to 15 mg total. Caution: glucagon is highly emetic when given IV. Lipid emulsion. IV lipid emulsion therapy lacks clear evidence for efficacy but may be considered if all other interventions fail. A bolus of IV lipid emulsion 20% at a dose of 1.5 ml per kilogram should be administered, repeated if necessary, followed by an infusion of 0.25 to 0.5 ml per kilogram per minute for 1 hour. Reports suggest that methylene blue, particularly in amlodipine overdose patients. Hope you understand pretty well. Thank you.